Good afternoon, or morning for me. I'm Peter Kahrilas, coming to you from Chicago, and I'd like to briefly discuss the latest developments on the cause of symptomatic reflux. So with respect to the management of initial mild to moderate reflux-like symptoms, and I would emphasize that most are mild to moderate, this should really focus on lifestyle modifications, weight loss, and the as-needed use of antacids or alginate, reserving endoscopy for patients who have alarm features such as bleeding, dysphagia, or weight loss. And that will usually work and is usually a sustainable approach. So in most instances, no diagnostics are necessary, and one simply addresses reflux-like symptoms. However, they don't always work, and sometimes there's clearly a failure to respond to this pragmatic approach. In those instances, one adds acid inhibition. Now, one approach to addressing reflux-like symptoms has been described as the ladder approach to reflux management, where one first addresses lifestyle issues and then adds a PPI, then adjusts the PPI in terms of timing, doubles the dose or splits the dose, increases the dose, switches to a different PPI, switches to a PCAB, and only after all that has failed goes to the non-acid blocking options or investigation. But there are some major problems with the latter approach to treating reflux-like symptoms. Gastric acid is the only target of this therapy. So it has led to an awful lot of long-term PPI use and high-dose PPI use, which in turn has led to intensive scrutiny of potential associated adverse events. And it's based on the Montreal construct, which assumes that reflux-like symptoms share the same pathophysiology as reflux esophagitis and the same dose-response characteristics to treatment. But this just isn't true. Each reflux phenotype has unique pathophysiology, and the only phenotype with a clear dose-response curve to acid inhibition is reflux esophagitis. The latter approach ignores the reality of the brain-gut interactions, and brain-gut interactions are very important. So, looking at these different syndromes, from Barrett's all the way to functional heartburn, you get a shift from demonstrable altered physiology to mainly or entirely altered perception. Now, when there's altered physiology, the modulating or predisposing factors are obesity, hiatus hernia, diet, and habits, and objective testing with endoscopy, pH metry, etc., can be quite useful. With altered perception, however, the modulating or predisposing factors here are IBS, dyspepsia, anxiety, depression, hypersensitivity, hypervigilance, somatization, insomnia, and fear. And non-PPI treatments are going to be more effective than acid inhibition. So behavioral medicine consults, neuromodulators, alternative medicines, or even mucosal protectants in some cases. So again, there seem to be behavioral as well as physiological determinants of symptoms. And that's evident in this prospective cohort study of 105 patients with pH impedance, dividing them into the three Rome-4 groups of NERD, reflux hypersensitivity, or functional heartburn. In terms of acid exposure time, this is, of course, how they're divided up. The NERD patients are abnormal at almost 9%. The other two groups are normal, and that's statistically significant. With reflux events, very abnormal in the NERD group, practically normal in the reflux hypersensitivity and functional heartburn group, using 40 as the upper limit of normal there. Mean nocturnal baseline impedance, you can show a difference. So the NERD group have subendoscopic mucosal damage, whereas the reflux hypersensitivity and functional heartburn groups are pretty normal. But the GERD-Q, which is an estimate of the severity of reflux symptoms as perceived by the patient, No significant difference between the three groups. And in terms of the EHAS, which is the esophageal hypervigilance and anxiety scale, there's no difference between the three groups. So the only thing that correlates with the perception of symptom severity is the EHAS score. Furthermore, although Rome 4 went to great lengths to distinguish reflux hypersensitivity from functional heartburn, there's absolutely no difference between these two by any of these metrics. So where does this leave us with the frontline management of reflux-like symptoms? Well, emphasize the importance of lifestyle and behavioral modifications. This amounts to encouraging weight loss, dietary modifications, adjust eating and sleeping patterns, use targeted therapy with PRN, antacids, and alginates, or H2 blockers instead of open-ended PPI therapy. Use psychometric tools or psychological assessment such as the EHAS tool, the esophageal hypervigilance and anxiety scale, early on to identify the perceptual drivers of symptoms. Be pragmatic about PPI use. Establish the need. Use diagnostic testing such as endoscopy and manometry selectively to tailor therapy and exclude alternative diagnoses that have alternative treatments. And that's the key. Alternative treatments. This amounts to high-grade esophagitis, motor disorders, and EOE. These are mainly patients with dysphagia. Breakthrough or persistent symptoms stem from some combination of reflux, hypersensitivity, hypervigilance, psychiatric comorbidities, and misdiagnosis. These rarely respond to the latter approach of escalating acid inhibition. Address brain-gut dysfunction with cognitive behavioral therapy and neuromodulators, and do this early on. Thank you for your attention.